Hello everyone, thank you for joining our second session for our Dermatology MLA teaching series. This session will be focusing on dermatology malignancies. So I'll hand over to Dr. Anisah Ali for the session.
Thank you. Hi everyone, my name is Anisah. I'm a doctor working in Birmingham. I'm an F1 and I'm interested in dermatology. So today I'm going to be delivering a session on dermatological malignancies. So we'll be going through some common benign lesions and malignant lesions and talking about how we can differentiate between the two and investigate and manage them. If you have any questions, feel free to put them in the chat. And we'll either go through them as we go along or at the end of the session. So just to go over some learning objectives as to what we'll be covering. So we'll talk about common malignant skin lesions, talking about their assessment, prognosis and management. So I'm sure most of you are aware the most common ones that we need to be aware of are malignant melanoma, basal cell carcinoma and squamous cell carcinoma. We'll talk about differential diagnoses, so benign nevi, seborrheic keratosis, dermatofibroma and pyogenic granuloma. And then we'll also talk about non-melanoma skin cancers and pre-malignant skin lesions, so for example actinic keratosis and Bowen's disease. So just very, very briefly as a recap of the anatomy of the skin, just to help lay the structure for what we'll be discussing later. But the skin is divided into three main layers. So we have the epidermis, the top layer, then the dermis, and then we have the layer of fat in the subcutaneous layer. So most of the important things are found in the dermis. So we have the nerves, sweat glands, vein, arteries, and sweat pores coming out at the top of the epidermis. So just some definitions before we go into the different types of skin lesions, just to make sure we're clear as to what they mean. So when we're referring to a malignant lesion, this basically is referring to a cancerous skin lesion, whereas if it's pre-malignant, it's not the point where it's cancerous yet, but it has an increased risk of progressing to a malignant skin lesion. And then benign lesions are non-cancerous lesions, so they tend to grow slowly and they don't really spread to other sites, so they're not anything too concerning. However, it's important to try and distinguish between benign and malignant lesions, because then we can determine whether urgent dermatology advice is required. So I've got some images here of some different skin lesions. So I thought that people could just put in the chat whether they think each one is cancerous or benign, just based on looking at it. If you think you know what it is as well, you can also say. So we can start with the one in the top left-hand corner, if anyone wants to take a guess as to whether it's cancerous or benign. Any ideas as to whether the top left or any of the lesions, do we think they're cancerous or benign?
So Janet has put that the first one is a seborrheic keratosis.
Cool, yeah, I agree. And do we think that's a cancerous or a benign lesion?
Benign.
I agree, yeah, benign lesions. So we'll talk more about sub-Ks in a bit, but I agree. What about the one to the right of it in the middle?
So Hannah has put it's benign.
Okay. So this is actually a malignant lesion. This is an example of melanoma, but we'll talk a bit more about melanoma and the different way it can present in a bit. Anyone want to take a guess at any of the other ones?
So the last one, so the one in the corner, someone has put it's a pyogenic granuloma.
Yep, well done. I agree, that is a pyogenic granuloma, so that is a benign skin lesion. I'll just go through the others for the sake of time, but we've got a basal cell carcinoma in the top right. So this is a cancerous lesion. We'll talk a bit about that in more detail in a bit. And then bottom left, we've got benign. So these are melanocytic nevi. So these are essentially moles that can pop up on anywhere on the body. Then we've got malignant. This is a squamous cell carcinoma. And as someone mentioned before, we have a pyogenic granuloma in the bottom right-hand corner. This is a benign lesion. So we'll talk about all of these. So firstly, if we think about our malignant skin lesions, so we can kind of divide these into two broad categories. We have the melanoma side and we have the non-melanoma side. So melanoma, malignant melanoma, can then be divided into several different types of malignant melanoma. So we'll go through the types, but the main ones are superficial spreading, nodular, lentigo-maligna, acral-lentiginous, and amelanotic. And then our non-melanoma skin cancer, the main two that we need to be aware of for finals are basal cell carcinomas and squamous cell carcinomas. There are lots of other types of non-melanoma skin cancers, but these are not as common, and for final years, we only need to know about these two. So, starting off with this image, so we're looking at melanoma here. So, does anyone want to put some words in the chat that they would use to describe this lesion?
So we have one answer, which is asymmetrical, irregular borders, and multiple colours.
Nice, well done. So I can see there that you're kind of using the ABCDE structure, which is exactly what I was going for. So well done. So when we're trying to distinguish whether a lesion might be malignant, typically people recommend using the ABCDE structure particularly for finals and in an OSCE scenario. So if anyone's not familiar with the ABCDE structure, it stands for A is asymmetry, so is the lesion symmetrical or is it asymmetrical? B stands for border, so is the border regular or is it irregular? C stands for color, so is it one consistent color or are there multiple different colors? Is it a mix of hyper and hypopigmented? Diameter, so I can appreciate the diameter is difficult to see in this picture, but if the diameter is more than 6 millimeters, then typically we're going to be a bit more concerned. And E stands for evolution. Again, difficult to tell from one picture, but what evolution means is that has it changed a lot over time? So within the past few weeks, has it gone from being very small to very big? And then on the side, it's also important to look at associated symptoms. So things like pain, itching, bleeding, crusting, scabbing. These are all signs that we should be a bit more concerned about that it might be a malignant lesion. So if we needed to describe this lesion in an OSCE scenario, the ideal way to describe it would be it's an asymmetrical patch because it's greater than 1 millimeter and because it's flat on the surface of the skin. So asymmetrical patch with irregular borders. It's hyperpigmented, or we could say it's multiple colors, as someone said before, with a diameter of 8 millimeters. And this image just illustrates nicely how we would compare lesions using the ABCDE. So we can see that, for example, if we're looking at the borders, so for the malignant side, we can see that it's quite difficult to make out exactly where the borders are. There's multiple colors, so there's a hypopigmented side and a hyperpigmented side. And if we look at E, we can see the comparison between an ordinary mole, and then we can see that it's grown really rapidly. There's different colors, the borders have become more irregular, so the lesion has evolved quite quickly. Okay, so can anyone think of any factors that might predispose an individual to skin malignancies?
So we have a great answer. Family history, sun exposure, sun tanning, immunosuppression.
Yeah, nice, well done. That's a really good answer. I would say those are probably the main ones to be aware of. So we've got exposure to ultraviolet or UV rays, so things like tanning beds. Skin colour, so we use the Fitzpatrick skin type scale. So type 1 is typically the lightest colour. So this is the type of skin that always burns and never tans. And then it increases up. So the fairer the skin, the higher the risk. Someone mentioned family history, really good. So particularly if they've got a family history of melanoma or other skin cancers, this is past medical history of melanoma or nevi. So if someone has more than 50 nevi, 50 lesions, they're going to be at an increased risk. And then the family history, so any types of skin cancer and increasing age as well is a risk factor. And this picture just shows the Fitzpatrick scale going from type 1 to type 6. So type 1, this type of skin that always burns, they're going to be at the highest risk. Okay, so as I mentioned before, there's different types of melanoma. So here we've got a few images, and I've listed some of the main types of melanoma. Is anyone able to match any of the images together?
So we have top left is acral lentiginous.
Cool, yep. I agree, well done. Any others?
Bottom left amelanotic.
Bottom left, yeah, cool, well done. What about bottom right?
Bottom right nodular, and we have top right as superficial spreading.
Nice, well done, everyone. So I agree. So superficial spreading is typically a type of melanoma that spreads horizontally, so it grows flat but outwards. Amelanotic, so we can see that it's a different color compared to the others. So it's typically actually a lighter color rather than that typical dark hyperpigmented color. Nodular, so in comparison to superficial spreading melanoma, nodular melanoma actually grows vertically, so upwards instead of outwards, so it forms that nodule. And then acral lentiginous, so acral meaning it's typically on the palms of or the soles of the feet, or sometimes on the palms of the hands as well. So sorry, those A's are meant to be dashes, but just reiterating what I said before. So superficial melanoma, it is progressively changing. It has a horizontal growth, so it grows outwards. That's the most common type that you tend to see. Then nodular, so this is where it grows vertically. It looks like a nodule, so it's going to be raised. It might have that vascular appearance and be pigmented. Then acral lentiginous, so this is typically flat and on the palms and the soles. And then amelanotic, a lot less common, but it's a non-pigmented lesion. Okay, so in terms of investigations for malignant melanoma, so first you just want to make sure you've done a full examination of the patient. So we can examine using the dermoscope, which is kind of the little like microscope that we use to look at the skin in more detail. And then what we can do is we can excise the lesion, because then we can look at the histology. We can also do a full thickness excisional biopsy, and if we're suspecting metastatic melanoma, we can do staging. So in order to do staging, we can calculate something called the Breslow thickness or the Breslow depth. So essentially the Breslow thickness is measuring the lesion from the top of the skin down to the deepest part of the lesion. So by looking at the depth, we can categorize what stage we think the melanoma is at and how severe we therefore think it is. So the reason why it's important to work out the Breslow thickness is because that helps to determine the staging, and then that helps to then determine how we're going to manage the lesion. So when we're thinking about staging, it's also important to think about if there's any lymph nodal involvement, or if we're aware of any metastases to anywhere else in the body, to any other organs. So when we're managing malignant melanoma, the definitive management is to surgically excise the lesion. So we usually tend to do an excision biopsy, and this is then followed by a wide local excision. So if we look at the picture on the right, so In the middle, we can see that we've got the actual melanoma lesion, which needs to be removed. And then when we refer to a wide local excision, we're basically creating margins around the lesion. And those margins are dependent on the Breslow thickness. So the deeper the lesion, the wider we're going to make that excision. So we mark on those borders, and then we remove that whole surrounding area as well to make sure that all the cancer cells are removed. Then if the melanoma is more severe, we can also do a sentinel lymph node biopsy, and we can consider radiotherapy and or chemotherapy, depending on things, again, like staging and patient preference, life expectancy, etc. So it's important to consider the factors that can affect the prognosis of melanoma. So some things I have mentioned, so Breslow thickness. Other factors are the mitotic rate, so the growth rate, how quickly is the melanoma growing, the location, so on the extremities, so places like on the limbs, melanoma will have a better prognosis than on somewhere like the face. Age, so prognosis will worsen with age. Growth pattern, so nodular melanoma is more concerning than superficial spreading, for example, because of its vertical growth. So as well as growing upwards, it can grow downwards a lot quicker and therefore spread to other organs more quickly. If the patient has distant metastases or lymph node involvement, that's going to worsen prognosis. And then females actually have a slightly better prognosis and secondary characteristics. So, for example, tumor ulceration, that's going to be a sign of worse prognosis. So it's important to think about all those factors when we're determining what treatment we want to do for the patient. Okay, I hope that all makes sense so far. If there's any questions in the chat, just let me know, but I'll keep on going. So, can anyone think of any differential diagnoses for malignant melanoma? I mentioned quite a few at the beginning.
So we have seborrheic keratosis, melanocytic nevus.
Yeah, nice. Well done. Those are really good ones. So I've also got benign nevi and I've got seborrheic keratosis. Two others to be aware of. I wouldn't say they so much typically look like what we would classify as melanoma, but dermatofibromas and pyogenic granulomas are also important lesions to be aware of. So we'll go through each of them. So firstly, benign nevi. So benign nevi are essentially a benign local proliferation of melanocytes. So melanocytes are the cells that are responsible for pigmentation in the skin. So when melanocytes just grow or proliferate a little bit more, then we tend to see benign nevi. And they can be congenital or they can be acquired. So they can be present from birth or they can develop later in life. And there's three main types of benign nevi. I'll go through the difference between them in a second, but they are junctional, compound, and intradermal. So in terms of managing benign nevi, if they're less than 5 millimeters in diameter and the border is uniform and it's kind of one consistent colour, so if we're not really that concerned about it, then we don't need to treat nevi. We can leave them as they are. However, it's important that we advise patients to regularly self-examine. So it's important, especially like from GPs, it's important to teach patients about the ABCDE so that if they do spot anything abnormal, they can come back right away, and then we can refer them onto dermatology on the 2-week wait pathway, 2-week wait referral. And in that way, they can be assessed as soon as possible, and they could potentially have a biopsy or excision if necessary. So, as I mentioned, there's 3 main types of benign nevi. So, junctional is where we have flat pigmented macules. So, these are the most common types of benign nevi that we see. And I'll show the histology in a second, but it's essentially where there's nests of nevus cells, and these form at the junction of the epidermis and the dermis, so between the top layer and the middle layer. On the other hand, we have compound benign nevi. So these are more warty compared to junctional nevi. So if you look at the picture below, we can see that it kind of looks like it's got a smooth surface, but it's not as flat as the junctional nevi. So these nevi form by nests of nevus cells in both the junction and the dermis. And then we have intradermal nevi. So these kind of look a bit nodular, they're a bit more raised, and they sometimes are skin coloured, and these form within the dermis. So if I show this picture, this will illustrate it a bit better. So we can see that we've got the epidermis at the top and the dermis below, and then in between the epidermis and the dermis we have the dermo-epidermal junction. So the junctional nevus is just basically at the top in the epidermis, so it doesn't go above, which is why the lesion is flat. Then we have the compound nevus. So this causes the lesion to be slightly elevated, so we can see that it's in the dermo-epidermal junction, overlapping between the 2 layers. And then intradermal, so hence the name intradermal in the dermis. So this forms under the dermo-epidermal junction, and that causes a dome-shaped or warty-shaped lesion to form. Okay, so that's nevi. Now moving on to seborrheic keratosis. So does anyone want to have a go at describing the lesion here? Any ideas how we can describe this lesion? Even just words. So I would describe this as asymmetric. So it's not symmetrical, it's brown and black in colour. I'd describe it as a papule because it's a bit hard to tell from the image, but it's likely a raised lesion. The borders are quite well defined, and it's kind of got that stuck-on appearance. So it kind of looks like someone's got a sticker and they've just stuck it onto the skin. So anytime you hear that phrase stuck on, people are typically talking about seborrheic keratoses. So seborrheic keratoses are very common in those over 50 years old. As I said before, it has that stuck-on appearance, and it sometimes has a smooth or waxy surface, which is easier to appreciate when you palpate the lesion. Seborrheic keratoses are a clinical diagnosis. However, if one is unsure, they can be referred to dermatology for biopsy or diagnostic excision, just to make sure that it's not a malignant lesion. So, if it is a seborrheic keratosis, it doesn't necessarily require treatment. It's not going to cause any harm, but sometimes they can be removed for cosmetic purposes. Okay, then we have dermatofibromas. So a dermatofibroma is a nodule of the dermis, and this grows due to overgrowth of fibrous tissue in the dermis. So sometimes dermatofibromas develop in response to trauma, or even insect bites as well. And they're typically described as a firm, rubbery, often it's a skin-coloured lesion as well. So with a dermatofibroma, you can do the pinch test. So when you pinch the lesion, it kind of dimples in and disappears. So if it dimples in when you pinch it, it's most likely a dermatofibroma. Sometimes they go away by themselves. However, they're not harmful, so we don't necessarily need to remove them. They can be quite deep lesions, and even if we do remove them, there's a high chance of them recurring. So most of the time they're not actually removed because it's better not to remove them and leave the patient with an even bigger scar, and then they might just reoccur anyway. So most of the time they're just left alone. Okay, then the last lesion is a pyogenic granuloma. So a pyogenic granuloma is caused by rapid vascular proliferation, and that gives it its typical bright red colour. So it's usually a nodule, so it's elevated, it sticks out, it's above the skin, and it has multiple different causes. Some of the causes are trauma, infection, typically Staph aureus, pregnancy, and medications, in particular oral retinoids, but there's lots of different causes. So pyogenic granulomas can rapidly grow at the site of trauma, and they can bleed quite profusely as well, given that it's caused by rapid vascular proliferation. The recurrence of them is quite common. So again, sometimes they're not removed at all. However, if we do want to remove them, we can use different methods. One is curettage and cautery. So curettage and cautery is essentially a scraping away the lesion and then applying a high frequency electric current to help stop that bleeding and then remove some of the tissue as well. We can also excise the lesion, or we can use cryotherapy. This is where we use kind of like ice, we kind of freeze the lesion to make it basically fall off. Okay, so now we're going to move on to some other types of skin cancers. So here we're looking at a basal cell carcinoma. So does anyone have any words or phrases they would use to describe a BCC?
So we have a red circular nodule with rolled border, edge, and dimpled midpoint.
Okay, cool, well done. So some really good words and phrases were used there. So I agree. It's I don't know why I said skin coloured here. It's actually more erythematous. It's more red here. I guess parts of it are skin coloured. It's hard to appreciate from this picture, but typically BCCs have surface telangiectasia as well. So when you can see the blood vessels at the surface. And I think we mentioned as well the rolled edge. So that's very characteristic of a BCC. We tend to use the word pearly to describe it. So again, difficult to appreciate in this image, but when it's kind of got that white shine to it, we use the word pearly, like a pearl, to describe it. Sometimes BCCs can be necrosed or ulcerated. This one's kind of got a dipped ulcer in the middle as well. So if you ever have a lesion and it's got the rolled edge, it looks a bit white or pearly, and you can see surface telangiectasia, think about a BCC. So there's lots of different types of BCC. Like malignant melanoma, you can get nodular BCC, superficial, lots of other types, but nodular is the most common, so the one that sticks out. And BCCs tend to present on the head and the neck. In terms of managing a BCC, so with skin cancer, the management tends to be quite similar between all the different types of lesions, but essentially the definitive management is to get rid of that lesion, so surgically excise it. For BCCs, we can use a special type of surgery called Mohs micrographic surgery, which I'll talk about in a bit. If the patient is not suitable for surgery, we can consider radiotherapy. And then other alternatives can be cryotherapy, which is using the kind of freezing technique that I mentioned before, or we can think about topical treatments. So an example is imiquimod. Okay, here we have squamous cell carcinomas. So squamous cell carcinomas can sometimes be preceded by pre-malignant lesions, for example, AKs or actinic keratoses. So SCCs, squamous cell carcinomas, are usually keratotic, so they tend to look a bit more scaly, crusty, whereas BCCs are normally nodular. These are more like papules or plaques, and sometimes they can be ulcerated. So going back to the picture over here, on the left, for example, we can see that it looks quite scaly and crusty. So again, very similarly to a BCC, we can manage an SCC by surgically excising the lesion. We can use Mohs micrographic surgery, and if not appropriate for surgery, we can consider radiotherapy. So just a little bit about Mohs micrographic surgery. So in Mohs micrographic surgery, what we're doing is we're excising the primary lesion, and then we follow that with excision of the borders to make sure that we're removing any microscopic metastases. So looking at the picture on the right-hand side, we can see the visible lesion on the skin, and then we remove one thin layer, and then we keep removing thin layers, layer by layer by layer, until we're sure that we've removed that final layer of skin cancer. Okay, so just talking about some pre-malignant lesions. So We'll talk about actinic keratoses. These are also known as solar keratoses, and Bowen's disease as well. So AKs, or actinic keratoses, and Bowen's are essentially precursors to squamous cell carcinomas. So the first image shows the normal skin, and then with actinic keratoses, these are considered pre-malignant lesions. So they're not cancerous at the time, but they increase the risk of developing an SCC. And Bowen's disease is a carcinoma in situ, whereas an SCC is more invasive. So here's an image of actinic keratoses. So these are more common on chronically sun-exposed sites. So for example, the scalp, the face, the hands. So if a patient comes in with new skin lesions, it's always important to ask about how long they spend in the sun, what they do for a job. It might be a job where they're driving a lot of the time and they're exposed to the sun, or they're working out in the heat. These are important questions to think about because it might point towards a diagnosis of an AK. So looking at the lesion in the left picture, does anyone want to give any words they would use to describe this lesion? So I would describe this as a scaly rough patch on an erythematous background. So we can see that it's got that scale, that white stuff at the top. It's probably going to be rough to palpate, and we can see that it's got a reddish erythematous background to it. So, actinic keratoses, like I mentioned before, they're a precursor to SCC. So essentially there's dysplasia of the epidermis, but it's not full thickness dysplasia of the epidermis. If an AK increases or thickens in size, or if it becomes tender or starts to bleed, so basically if anything starts to grow or look more worrying, it's more likely to progress into an SCC. Important differentials to think about are Bowen's disease, also psoriasis. It can look very similar to psoriasis, and it's important to think about whether it could actually just be an SCC or BCC. So it can be quite difficult to differentiate between them all sometimes, which is why we can use dermatoscopy to look in more detail, or we can do a biopsy of the lesion. In terms of managing an actinic keratoses, so it depends if it's on a more discrete or a larger area. If it's in a more discrete area, we can use sun protection. So we try to encourage using high SPF, so like SPF factor 50. If it's a solitary area, we can use cryotherapy. Otherwise, we can always use surgical options such as excision, curettage, and cautery. If it's a more larger area and we're not going to be able to just excise the area of the lesion or multiple lesions, we can use topical treatments. So recommended treatments are diclofenac gel, 5-fluorouracil cream, and imiquimod cream. And we can also use photodynamic therapy. Okay, then we have Bowen's disease. So Bowen's disease is what we can call squamous cell carcinoma in situ. So in Bowen's disease, there's growth of the malignant keratinocytes, and this is confined to the epidermis. Bowen's disease can progress to SCC, like I mentioned before. So there's a lesion in the bottom left-hand corner. To describe this, I would call it asymmetrical. It's erythematous, it's a bit scaly, and it's hard to tell from the picture, but slightly raised, so it's a plaque. So again, Bowen's disease is common on sun-exposed sites. It can be a clinical diagnosis, but if unsure, we can do a biopsy. In terms of managing the lesion with any skin cancer, it's important to encourage sun protection. And then we can use different creams. So one that I mentioned before is 5-FU, so 5-fluorouracil cream. So this cream is a analog that binds or irreversibly binds within the cell to a certain enzyme, and that prevents the incorporation of part of, thinking back to DNA, so the incorporation of uracil into nuclear RNA, which destroys abnormal cancer cells. So basically the cream acts to destroy those cancerous cells. There's also the imiquimod cream, there's photodynamic therapy, and again, our surgical options, so cryotherapy, excision, and curettage. Okay, so if there's any questions, just let me know. But just to finish off, we'll just go through a couple of quick cases.
We do have one question which I've put on the Q&A, so we can discuss it after case one.
Yeah, sure, no worries. Okay, so we'll go through case one first. So we have a 58-year-old male who presents with a skin lesion on his back. So what other information about the patient and lesion would you want to ask about?
So we have, has it progressed since its first appearance? Time scale? Is it painful? And has this occurred before?
Cool, yeah, well done. Those are all really important questions to ask. So we asked the patient more about the history. This is what we get back. So we've got a lesion that's present on the trunk. It's dark, 8 millimeters wide and slightly raised. It was smaller a few weeks ago, and the patient's had some itchiness and discharge. So this patient is Fitzpatrick skin type 1, and he's used tanning beds in the past. He has a past medical history of previous moles and a family history where his mother had melanoma. So Oops, this next bullet point wasn't meant to come up, but that's okay. So this is nodular melanoma. So in terms of investigations for nodular melanoma, so say that we're in an OSCE scenario, you want to think about simple things we can do. So obviously examining the lesion, doing a full dermatological examination, not just of the lesion, but of the whole skin. We can do a swab if we're worried about it being something infectious. Then we want to look at the lesion in more detail, so we can do dermatoscopy. And it's also important to do photographic documentation of the lesion as well, because then we can track if it's changing over time or not. So in terms of managing the lesion, the definitive management is going to be a biopsy. So we can do an excision biopsy, and then it depends about the size of the lesion, which we're not sure of here exactly. Here we said it's 8 millimeters wide, so we could do 2 millimeters margin around the lesion. Okay. Did you want to ask that question now?
Yeah, so the question is, does an early stage seborrheic keratosis look the same, or do they mature to look like the image, so the stuck-on appearance?
That's a good question, to be honest. I'm not really sure. I think it can depend. I imagine that they're not just overnight gonna look like the way they do on the images. So they're probably gonna start quite small and not have that stuck-on appearance initially. It might just look something more like a nevus, and then start to grow and get that stuck-on appearance. So it can be quite difficult, to be honest, to first see a seb-K and actually recognize that it's a seb-K. So I guess if anyone's concerned, it's important just to go to the GP right away, to be honest. But I think it varies from person to person. Okay, so case 2. So we've got a 72-year-old truck driver who presents with a few-month history of multiple lesions on his scalp, which are becoming increasingly tender to touch. So, are there any other questions you'd like to ask? What do we think is the most likely diagnosis? And if you want as well, we can put in the chat, is there any investigations you would do and how might you treat the lesions?
So we have actinic keratosis, investigate with dermatoscope and biopsy.
Okay, cool. So yeah, well done. This is actinic keratosis. So it's very common on the scalp, and with AKs, they tend to present as multiple AKs. So lots of AKs around one site. In terms of investigating, I agree. So we always want to do our full dermatological examination, dermatoscopy to look in more detail. If we're not sure, we can excise and do a biopsy of the lesion. In terms of differentials, so an important differential is psoriasis. Psoriasis is less common on the scalp. However, psoriasis can sometimes look a bit rough and scaly, similar to an AK. With psoriasis, it's important to think about kind of past medical history, family history, any exacerbating factors that may have caused psoriasis to help rule it out. Other differentials, subkeratoses. This doesn't really have that typical stuck-on appearance. It's a bit more varied in colour. It's got crust and scale, so less likely. SCC, hard to differentiate. It would probably require a biopsy to be sure. And the last important differential is seborrheic dermatitis, because this is very common on the scalp as well, particularly around the hairline. Okay, and then last one, so case 3, describe the lesion, and also what investigations and management would you advise, and what advice would you give to the patient?
So we have asymmetric, well-demarcated border, brown and black pigment.
Cool, well done. I agree with all that. Anyone have any specific investigations or management you do or advice you'd give to the patient?
Yeah, so we also have different colours present, and advice to refer to dermatology for removal. And someone has written as a differential, spreading melanoma.
Yeah, cool. Well done. So, exactly as someone said, so use your ABCDE. We've got the asymmetrical patch. It's irregular, it's hyperpigmented. The diameter is big. This case is 8 millimeters. So we want to examine the lesion with dermatoscopy, do a full thickness excision. If we stage the melanoma as 1B and above, then we tend to do a lymph node biopsy. To manage it, we would excise the lesion and we can consider radiotherapy or chemotherapy. And then it's really important that in the management we also counsel patients on how to self-examine the skin using the ABCD technique, and also advise them on sun protection too. Cool, so this is just a little recap from the beginning, so I'll just go through them. So we had SEB-K, that stuck-on appearance. As someone mentioned before, it might initially not always be stuck on, but as it develops, it does tend to have that stuck-on appearance, and that's a benign lesion. We have a malignant melanoma, so this is a nodular type of melanoma. We can see the vertical growth growing upwards from the skin. Then we have cancerous, so a basal cell carcinoma. This one doesn't so much have the pearly rolled edges, but we can see it's kind of ulcerated in the middle, and it's on the nose, which is a very common site for BCC. Then we've got benign melanocytic nevi. So it's quite common to have multiple nevi, as we can see here. They're all one uniform colour. But the most important thing is to look at how they're evolving, growing, changing over time. Then we've got a SCC, which is malignant. It's got secondary characteristics here, like crusting. It's multiple colours, so it's going to be a more concerning lesion. And then lastly, we've got a pyogenic granuloma, which is benign. It's got that typical red colour, but we don't necessarily need to do anything unless it's causing problems. Okay, that's everything. Thank you for listening. If anyone has any other questions, feel free to put them in the chat. Otherwise, thank you for coming. And if you could please fill in the feedback form, that would be really useful as well. Thank you.
Great, thank you, Anisah. I don't think there's any more questions.
Okay, cool.
Thank you.
No worries.
Yeah.
Okay, thanks for joining, everyone.